Qual é o assunto agora? Lições e aprendizados da jornada africana. Como fazer melhoria em larga escala? Eu anunciei, é o diretor executivo do Ubora Institute e especialista africano que iniciou o projeto Fives Alive em Gana. Então, ele vai falar sobre este assunto, lembrando que nós vamos ter 10 minutos para perguntas ao final, a mediação da Luciana Yumi. Combinado? Ernest, welcome.
Thank you, and good morning. I will, in this session, go through what it takes to do improvement work on a large scale. So I will share some lessons and experiences from Africa, precisely on our the Project Fives Alive project that I mentioned about yesterday. Yes, so usually, as I alluded to yesterday, improvement work is usually about trying to close gaps. So if it is a coverage gap, how do we close it? It is a patient safety gap, how do we close it? And indeed, we all acknowledge that what works in terms of evidence is usually out there. But how do we bring it into the implementation level and really close the gaps and see those results reflected on a bigger scale? And so I would again refer to one of the slides I used yesterday, talking about the quantity of services, the quality and safety of the services, reliability, and making sure that all this is situated in the context of patient and family-centered care. So what are the healthcare challenges related to scale-up? We did also see from some of the presentations yesterday, precisely from the Armstrong Institute, that did mention that healthcare in itself is usually behind other industries in terms of uptake of innovation that produces results. We know aviation industry is up there. There are other industries that are up there. Yes. Okay. Yes. So generally, we see that there's usually a resistance to standardization. I don't know about what the situation is in Brazil, but it is pretty common in Africa, where much of it is human-centered, where the doctor or the physician is seen as a standard, and whatever he or she says, that becomes the norm. And we know that individuals, sometimes cause errors. So, so moving to that state of standardization is critical. Number two is usually the fact that most of our teams or our facilities that provide care, whether to improve access or improve safety, hardly work as teams. We need to work more as multidisciplinary teams rather than just work in silos. So you have, say, an ICU that just works as an ICU and probably is not well linked to administration that provides the inputs for ICU. Then, and that ties in very well with the approach to systems. Healthcare in Africa generally doesn't have a culture of systems thinking. That culture is non-existent. It's very focused on specific clinical type of interventions. So if somebody wanted to reduce malaria infections, for instance, they just focus clinically on malaria and they don't appreciate the systems dimensions that relate to some of the issues around improvement of malaria. And so it's very common that, for instance, if there was a neonatal death in a hospital, say in Ghana, very common that the midwife who delivered the woman will probably be blamed because she probably didn't use the pathograph to monitor the progress of the labor. So it's a system that tends to blame rather than improve. and sometimes the data that emerges is used for blame or judgment rather than used for, improvement. And so we have some of these things. Then there's usually the concept of trying to work as a health system because we think we know best. So I am the expert, I'm the pediatrician, so I know it all. So a child is brought to me, and in administering care to the child, I just do what I think is the best. I don't really communicate with the patient. I don't really communicate with the mother. We have that type of thing. But there's a growing wave in Africa now that patients are beginning to demand to know what is going on. They want to be part of the processes of care in terms of that. But there's this long-standing problem, like I mentioned. So within that background, it's even further challenged because more often than not, there are limited resources. I mean, we know Africa, most countries in Africa are developing countries, lower and middle income countries. There are resource challenges, inputs, human resource. You never really get the type of staff mix. I remember working in one of the districts in northern Ghana. They had about 25 primary facilities. And the hospital that the primary facilities referred to didn't even have a physician. There was no doctor. They didn't have a doctor. And it's pretty common. It can be that challenging sometimes. And there are issues about financial access. Most of the quality healthcare services in most of the regions are not covered by insurance. And in the cases where they are covered by insurance, they only pay for some components and don't pay for others. So financial access is also quite a big issue. And then there are issues about geographical barriers. There's a huge infrastructure deficit, especially when you go into the rural Africa, where you don't have access to roads, things like bridges are usually not there. So this is very typical in that type of setting. So against this background, you have all those challenges I mentioned earlier. And of course, the weak governance systems. Ultimately, the public sector sometimes has weaknesses in how they manage things, and it's not really peculiar to the health sector. The other sectors too are very similar, and so you have some of these challenges. However, we know that there are loads of ideas, studies have been done as to how we can actually diffuse technology, innovations, and take it to scale. But the reality is, it doesn't really happen too often. We don't really see that too often. And so, yes, so the evidence is there that, yes, you can take this good idea and let it go far and wide, but usually we don't see much of that. This was a slide that came up in one of the presentations yesterday as well. And basically it's the same thing. So the old way is we focus on designing a program to improve quality, to improve safety. So we just focus on the paperwork. We design, then we go and implement. Then we hit a roadblock. It is not a success. We go back and we design. It is something that is so common in all the sectors, not just in healthcare, in Africa. And so this methodology over time has not proven to give us the kind of results we want at that scale that we might want it. And I remember I did mention also that most of these things have to do with a couple of stakeholders that need to understand what it means to have the will, not just the will at the beginning of the programs or the projects and the ideas, but also have an execution mechanism that can really grind out results and make sure that those results go to scale. And so usually you have leadership at various levels, led by usually the government sector, the ministry, and all its agencies, where it's very critical that they focus on what are the priorities, what is the framework for improvement, what is the guidance, so that when initiatives come, those initiatives will align properly. And then there are also issues about funding. I mean, in much of Africa, the funding gap is huge. Most economies do between 2 to 5% of GDP in healthcare, when we should actually be doing more. I know Ghana, for instance, the last UN statistics I saw, it was just about 2.8% of GDP in healthcare. So there's a funding deficit. And we also know that there are various donors and funders who come to assist. You know, how do we bring that conversation together so that we identify that there are systems, priorities, there are implementation mechanisms that are uniform, that are aligned, and how we can chart a course. And usually this should be defined ahead of time. And all the stakeholders, including implementation partners, like what happened in the 5 Life project, should then buy into this agenda, align the resources, and develop these initiatives in a way that is evidence-based, and then take this evidence to scale, and then so that we can see results. So, about the learning system, we know that a learning system is very important. And the model for improvement has proven to be very effective. In most parts of Africa I have worked, it is the framework where, you know, people use to develop change ideas, test those change ideas, and then are able to, you know, implement those change ideas and later spread those change ideas. So this is a very good framework that allows us to do that. And the Breakthrough Series, collaborative approach, that has been popularized by IHI, has also been proven to be very simple to promote peer-to-peer learning in an environment of all teach, all learn. And this has been very good. And so I'll come to it much more in the 5 Life initiative. So in summary, this would be the new approach as to how to create a learning system that actually finds ideas, vets those ideas, tests those ideas, and see what works before we can then go ahead to implement ideas and then spread them. So, what is this old way I mentioned? I recall yesterday I mentioned that usually the fragmented approach to quality was a huge issue. No structure, no vision, no framework. We also had issues where we had excellent work, but just happening in small pockets, a lot of them. You don't really realize results at scale with that. And then, where most of these initiatives inadvertently are usually led by partners rather than by governments, by states, you know, where they need to set the direction. And then, a situation where because of the poor quality data in the public's routine health system, you see most projects and most initiatives attempting to collect data on the side. At the end of the day, it might be good in the short term, but usually doesn't help the health system in the long term. And so that has also been a problem. And then a heavy focus on activities. I alluded to that. So look, going forward and seeing what is beginning to emerge in Africa, in some of the countries, Ethiopia, in Namibia, in Liberia, in Ghana, and some of those other countries with the various partners. What is happening now is that you now have a broad quality agenda defined by the country, where they align quality, not in terms of quality control, which is heavy on inspection, but more of Durant's definition of quality, where it talks about quality planning, quality control, and then that of quality improvement. And so setting this framework, very critical. Also important that for every QI project, or every project or initiatives that are beginning to emerge, there is a grand plan, right at the design phase, to have a scale-up, where the scale-up should eventually affect all the regions, all the districts, and so on and so forth. So yes, you would start small, but even before you plan about starting small, you should begin to think about scale-up. That is where you can really get results at scale. That is also very significant. We are also beginning to see countries increasingly engaging partners and saying that this is what we want. This is really what we want. We want to make sure that maternal health, child health is a priority. We want to make sure that surgical and medication errors begin to come down. What do we need to do? What are the measurement mechanisms? What is the organizational setup of our agencies in healthcare to be able to deliver that? So that conversation is going forward, and we are beginning to see more of this. We are also seeing that usually it is very important that you align your data systems for each initiative to help improve the routine data system. And every other data that does not exist in the routine system, you can then collect it as supplemental data. That is also very critical. And then The focus should no longer be how many health workers have you trained or how many trainings have you had in a year. It is now, what did you do? What are the results? And what are the outcomes? That should be the conversation. Because we really, really, really want to reduce suffering, improve care and utilization of resources, and then reduce mortalities and morbidities. So the focus should really be about outcomes. What is the effect of all what we are doing? And unlike previous projects that usually would focus more on clinical interventions, we are now beginning to see situations where there's a deliberate attempt to teach profound knowledge. Yes, you need to understand variation. How do you really look at data over time? How will you be able to tell whether a change is an improvement? You know, are you seeing any shifts or any trends in your data, in your run charts? These are the kind of conversations that are beginning to go on. We also have situations where the PDSA is widely now used to develop ideas, to test ideas, and also to implement ideas. That is also beginning to emerge, which is more of profound knowledge. And then organizing this whole setup, making sure that the front line where the action really happens, there are teams, and that we have patient representatives on these teams, and some of these teams go across to opinion leaders right at the base. So, what then would I advocate as what a framework for scale-up should be like? And this is what I'll put in this simple slide. If you observe, first of all, we need to build a will. Given all what I have talked about, let there be a clear vision with a framework with all the indicators and the key priorities defined. Very clear. Let's make sure that this is not just a vision that is led by partners, but it's actually led by the country or the states, where the partners buy into it, you know, and align their resources as such. We also need to make sure that we build capacity. More often than not, we are not usually coming to teach subject matter knowledge. Subject matter, we have the pharmacists, they know all the standards, they know what they should do. We have the physicians, they know the standards, the protocols are there. In fact, we even go ahead to summarize some of the protocols into bundles, clinical bundles. That are key things that ought to be done in terms of the process of care, to make sure that care is safe and is effective. The question is, do they also have enough improvement knowledge? Sometimes not. We still continue to analyze our data with bar graphs over time. We put our data in tables. We really don't get a lot of meaning. We don't communicate the meaning to be able to take decisions at the local level. So empowering all levels of the health system, right at the facility level in the various units in the wards, also engaging communities to understand what the data looks like, what the implications are, listening to the voice of the patients, and all that. Very, very critical. Very critical. And it's something that we have to look at. I'll go more into the 5-star life experience. What is important is that there's no single category or type of capacity you need to give to every level. You need to define it and see what type of capacity will you build at what level at each of the various levels. And so for instance, should you be teaching issues about theory of profound knowledge to somebody who is at the front line? Maybe not. But if somebody who's going to lead an improvement work in a region will probably need to have deeper insight. So it's about building broad and deep capacity. You know, actually cascading it at the various levels. Very important. And the data support, for me, has always been an African challenge. I know maybe in Brazil, with our patient safety initiative, it might also be a bit challenging, where a lot of the data on some of the key things you want to look at either don't exist, or if they don't exist, they're not properly documented. So again, earlier in the conversation, it is important to figure out what are the cross-cutting indicators, what are their definitions, so that there's uniformity in terms of collecting that data and doing a lot of the work. So first of all that goes into the setup. So all these key factors go into what you mean by setting up your project. And when you set up, please set up and test on a small scale. And that's what I call develop a scalable unit, find and test implementation, and then develop a change package. I'll go more into the change package with the 5-star life experience. And then once you develop the change package, down then becomes a blueprint that you can move a lot of that type of high leverage interventions and suggest them to a lot of the other teams who will probably get a rapid turnaround in terms of results, you know. And then, of course, you cover the entire area. I know in Brazil, Brazil is a very big country, and so covering the entire area will be challenging, but you can face it. Yes, in Ghana, we have 10 administrative regions. We faced it quite a bit. So let me now use this opportunity to quickly go and give you highlights of what the journey was on the 5 Alive project. So the 5 Alive project all was about making sure that we reduce Ghana's under 5 mortality by 2/3. Ghana was doing between 110, 120 per 1,000 live births. And that was a huge burden of mortalities for children under 5 years. So the goal was to make sure that we assist the country to accelerate this reduction to by 66%. By 66% by 2015. And so this was it. But the methodology that was chosen to be able to help the country do this was the using the quality improvement approach, where we set ambitious aims, we understand, we try to see how the system looks like, to understand what are the bottlenecks, what are the gaps, develop the metrics, the relevant measurement mechanisms, and then start the rapid cycle testing to see which interventions really work. And so the collaborators were, of course, the IHI partnered with the Ghana National Catholic Health Service. That provides about 20% of healthcare in Ghana. Also with the Ghana Health Service, which is a public service provider, providing over 70% of healthcare in Ghana. And there were other partners like the University of North Carolina. That was the independent evaluator of the project. So that they stand aside and see how well this was being done. And the funding was from the Gates Foundation. So this was at the design phase. Right at the design, this was what was planned in terms of scale-up. So the setup was in 2007, and then in July 2008 was the launch of the project. And the project was just launched at first in just 3 sites. So if you look at it, there was a systematic design to scale up onto the whole country. I'll refer to it later. Now you realize that at the prototype phase, which is the wave 1, in wave 1, we were just doing about 30 quality improvement teams. By the time we would have scaled up to the whole country, we were going to do over 1,000 quality improvement teams. And that was significant. But we needed to go it gradually. I'll go to the specifics. So yes, so this was the design part of the work. 30 teams. This was within the Catholic Health Service system of health centers, 6 of them. This was 1 district in Northern Region, and then that was 2 districts in Upper West. Together, considered 30 teams. So each of these represented a learning network. So there was a learning network within each of the sites. And the selection of the sites was not arbitrary. It looked at some of the areas where the heaviest burdens of mortality were. So much as Ghana was doing as at the end of 2008, we were then doing about 80 per 1,000 live births as a country. Some of these regions, for instance, in the Upper West region, was doing over 120. So the burden was much higher. So sometimes it's important that when you are prototyping, you take it to where you have the worst burden of what you want to improve. Very critical. That's where you can harvest a lot of learning. Number 2 is that you spread the sites to the places that most have the health system's challenges to see. So that if it works there, then most likely it will work in other areas that are relatively better with resources. And so that was what happened. The target, as you will realize that, as the third question will say, not every change leads to an improvement. I think this is a very profound statement, which is the third question. Not every change will always lead to an improvement. We are looking for the changes that lead to an improvement. And with the kind of results Ghana was getting, you cannot accelerate results doing the same things over and over again. It was going to be important to focus on a second type of change, which we call the fundamental change. The first level changes were not the changes we were interested in, because these ones really are just reactive changes. They don't really take us far. The second level changes, or which we call the fundamental changes, were really the changes we're looking at. Yes, we want to create a new system of performance, and as Gibbon says, where he defines quality improvement as the organized creation of beneficial change and the achievement of unprecedented levels of performance. It's going to be very significant that we focus on changes like this, and this is what 5 Alive really did very well. So it was about redesigning systems of care to alter results fundamentally, and we're trying to achieve long-term impact rather than short-term gains. And so these were the results. These are just a few of the results we saw. So you would see that when this whole project was launched, somewhere there, consistently, for some of the key indicators, we saw a consistent improvement of some of the processes as postnatal care. The thing is that the burden of under 5 mortality was heavy on neonatal deaths. Very, very heavy on neonatal deaths, which is the first 1 month of care. The first 1 month, very, very heavy. So a deliberate attempt was to focus a lot of the interventions within where most of the weaknesses were. And we decided to see how we could develop changes around early postnatal care and having at least 2 visits within the first week of life. And we saw these results over time. Very, very profound, compelling results. And so we knew that, okay, getting this success at that level in these sites was in itself not the end. Because we could have said, oh, we keep on doing it there, we're having good results, and we keep on. But the main goal, as we originally planned, was to go national. So how do we make sure that we take all these good things and see whether you can then, it's feasible to be able to test some of these changes or implement some of these changes on a bigger scale? That's one. With the implementation of some of these changes at a bigger scale, was it going to yield comparable results like we saw in the sites? That was one question we needed to ask. And could we sustain these type of changes? And that was another question we needed to ask. So we then looked for a form of assessment of the changes that really worked, that were really cost effective, and that could turn around results in a relatively shorter time. So out of over the 100 changes that were tested across these 30 teams included 2 hospitals and over 50 facilities organized into the 30 teams. And so there were a lot of changes, over 100 of them. The issue was to make sure that some of the things that related to delivery care that had impacts on under 5 mortality, we vet these change ideas and then tease them out. And then that of early postnatal care and under 5 care. So we had a number of change ideas in different categories, but not all the change ideas made it into the change package. I think this is very important because not all the changes will always lead to an improvement. We are looking for the changes that are proven to give us results. And so this is just a schematic that helps us to appreciate how we develop the change package. So at the end of the prototype phase, which was a period of 18 months, we then developed the change package. So I'll go into it. And this is how we did it. Because usually the question is, how do you do it? How do you do it? First of all, we looked at, for all the changes, we looked at an inclusion criteria. For you to qualify to be assessed as a change idea, we should have collected data, baseline data, for at least 6 months going backwards. So we should have some appreciable baseline. Number 2, we needed to make sure that this change was being tested for another minimum of 6 months to see whether we could see evidence of improvement, whether there was a shift, there was a too few or too many runs, or there was a trend. And this was also important. Then we then used it we then developed an assessment criteria where we said that if you scored 0 or 1, you will not make it into the change package as a change idea. If you scored 2 or 3, yes, that means that your change was efficacious and it could be included in the change package. And so we did that. And by the time we did this assessment, this was the summary of the change package. We had a how-to guide for each of the ideas, but this is just a summary of it. These were the interventions that were proven to have worked because we had data for each of them as the criteria explained, and this was the change package. So over 100 change ideas, eventually we had just 18. These are just 18 that proved to be what? Have evidence that they really work. And these were the ones that we used to scale up. So if you talk about scale up, you should have a core set of interventions that you are going to carry to that bigger scale and suggest it to people to test. That's where they are likely to get a quick turnaround with results. And this was exactly what we did. And so we moved on we then scaled up to wave 2, which was the first scale-up phase. which was in the northern part of the country, in 3 regions out of the 10 regions in the country. And whilst we were doing that, we realized that these interventions were very heavy on the primary facilities, health center and rural clinics. We had a few hospitals. So we needed another type of learning to see what works at the institutional care division, usually within the hospital arrangement. What are the kind of processes within hospitals that are really relevant? So we also decided to do some testing, which we called Wave 3, in hospitals in the south, so that we could also come up with a package that was very effective for reducing mortalities in hospitals. And that is where we talked about the patient safety issues and then the effectiveness of care and so on and so forth. And so this was the theory, the fundamental theory we applied to be able to do this. So this is a change, a driver diagram that itemizes the causes of under 5 mortality that we saw in our hospitals across the country. And one was delay in seeking care. Somehow a child gets to the care center very late when the physician can do very little about the situation. Number 2 was even the hospital systems themselves were very slow and irresponsive. The triaging systems weren't very effective. Fast tracking wasn't very good. And so these were critical issues. And then also, as and when care was supposed to be provided, in most instances, they were not really provided very well. They get some part of the package of care and some part is left out because either there are supply issues of medications and so on and so forth. So this was the uptake. So we piloted on 9 hospitals in the south. We spread it to 32 hospitals, 68 hospitals, and eventually 202 hospitals. That was for the hospital learning network. And that was the change package that was developed for hospitals. So we had 2 change packages. One focused on primary care and one focused on institutional care. And so these were the key results I just want to share with you. Just two of the indicators. So we saw that once we did that, issues about things like adherence to malaria protocol, which was a key driver in mortalities for under 5 care, the adherence level increased. You could see that we're not doing too well. In some cases, just barely 75%. So maybe 7 out of 10 children who came were getting the right care. There was a gap. So we had to close that gap, which we did very well. And then we also saw things like emergency CS response time also come down significantly. You know, a response time of over 100 minutes came down to a response time of under an hour. In fact, the World Health Organization gave, I think, a benchmark of recommended not more than 45 minutes emergency CS response time. So we began to see that these things also improved. And these were ultimately the results. Eventually, by the time we had scaled up to all the 140 hospitals, which was the national scale-up phase, the last part of the work, in the 7 regions, we saw a 35% reduction in under 5 mortality. What was significant was that much of this was accounted for from the malaria case fatality. Children who were dying due to poor treatment of malaria improved significantly. We saw a reduction of about 38%. That was also very significant. So to summarize, I just have key points that I want to, I think this is about my last slide. That one, for you to scale up, you need to appreciate your contextual factors. Every country or every region is different. You need to be able to contextualize that and come out with what you really want to scale up. You don't scale up anything. Scale up is not about the size, it's about the thing. What interventions do you want to scale up? Are they proven to work? It's very critical. Number 2 is also to recognize that healthcare is a very complex adaptive system. So your design should be adaptive. There should be some learning as you go along. You should be able to tweak your design as you go along. You can never have a definite design right from start. So be prepared to amend. It's also important to have a broad coalition of stakeholders, right from the patient up to the national level, the ministry. Everybody has a role to play. These roles should be outlined and communicated clearly, and feedback should constantly be flowing in for you to be able to do your adaptive design. And leadership is key. And in improvement, leadership is not about management. It can start with management. It doesn't end there. Even those who provide the services at the front line are also leaders. In the communities that the services are being provided for, there are also leaders. The engagement of patients and their families, there's some leadership type of engagement there because they're also leaders of care. And then lastly, it is important that we identify the various cadre of people among the stakeholders and build improvement capability over time. And then data. In the learning system, it is important that we learn from our data. And I think that is important, and the framework allows us to do that. So that is it. This is a guide I will recommend to you. All the details are in here as to what went on with the 5-Star Life project, what are the key learnings. It is 59 pages. There's a lot of stuff in there. I have a copy. I can leave it with the project team. You can also go online. It's online. You can get it. I'll get you the link as well. Thank you very much.
You deserve it.
Sorry, I think I
keep it with you. Okay. It's yours. It's yours. Okay. It's yours too. Nós é que agradecemos, muito obrigada mais uma vez ao Ernest Kanyoke por compartilhar conosco essa realidade africana e tantos bons resultados. Que coisa boa sempre podermos aprender e ver que realmente funciona quando algo é aplicado com dedicação e com empenho e com engajamento de muitos. Por gentileza, Luciana Yumi, aqui no palco para a mediação dos 10 minutos de perguntas. A Luciana é técnica da Coordenação Geral de Atenção Hospitalar do Ministério da Saúde e, mais uma vez, faz essa moderação junto ao nosso convidado, Ernest.
Bom dia a todos. Acho que é um deleite a gente ouvi-lo novamente, porque ontem nós tivemos um gostinho e hoje nós tivemos o final desse saboreio das informações que vocês trouxeram. Na verdade, você conseguiu trazer um preview daquilo que a gente espera conseguir com a segurança do paciente no nosso país. Conseguir fazer essa escala no nosso país tão grande é um sonho, né? É um sonho que nós cultivamos com esse projeto e com outros projetos que já temos aprendido a falar da segurança do paciente, a dar valor àquilo que é a melhoria da qualidade. E a primeira questão que não quer calar, na verdade, é como vocês escolheram os parceiros para essa empreitada. Eles se ofereceram ou vocês buscaram isso?
Okay, thank you. Look for partners. I think it was more evolutionary. We didn't define the partners right from start. There were partners who were relevant at the start, and the key ones I would say is the national government. Very important, because in the Ghana situation, the public health sector alone accounted for about 70% of healthcare. So if you wanted to do a national scale-up, you needed to do a strong engagement. And what was critical for us in Ghana was to make sure that we aligned with a national priority. So under 5 mortality was a national priority. So there was that alignment. And then, of course, the agency that was responsible was the Ghana Health Service. The next one, which also provided almost 20% of care across the country, was the National Catholic Health Service, which was another key partner. And the National Catholic Health Service had indeed expressed interest to adopt quality improvement as a way of doing business within the healthcare system, within their healthcare system. So the alignment was a very strong and good one to that effect. There were other partners as community members, people like transport unions, because in Ghana we don't have a very strong ambulance system. So in the rural areas, for instance, typically, if a child was ill in a critical condition, the child might be brought in by a taxi or as a rural transport system they call a trotro, for instance. So we didn't see these ones up front, but by the time we were about to scale up, we realized that these were important key stakeholders and partners, and so our design was flexible enough for us to bring them to the table, to talk to them. The other key partner that we also involved as we went along was traditional authority. In Ghana, most likely, when somebody is sick, they usually would seek permission from their traditional head before they go to the hospital. In some of the areas where culture is really very strong. And so it was important to get a buy-in of these people. And so over time, we added them onto the partnership, and we communicated. They participated in learning sessions. They participated in dissemination reviews, and then they helped to design the project as we ended it.
Muito bom, obrigada. Questões bem interessantes aqui. A próxima é quais os erros trouxeram aprendizado durante o projeto?
Which mistakes brought learning opportunities? Yes. The first mistake, and I wouldn't really call it a mistake, it's just something that was very natural to the healthcare system, is that you approach a clinical problem usually with a clinical solution. So when we looked at our condition in Ghana, the main causes of under 5 mortality was malaria, usually for children who are 1 month to 4 years, was a very big killer. Number 2 was the neonatal causes. There were basically 3, which accounted for about 80% of all the mortalities in the first 1 month of life. And there were birth asphyxia, neonatal sepsis, and then prematurity. So approaching this type of gap by just getting only clinicians who know about it in a disease-specific way, with just clinical interventions alone, didn't take us far. Because we realized that the problem in most of the facilities was not that people couldn't treat malaria, but as and when the child was sick, for instance, the medication, the supplies to provide medications for the treatment were usually unavailable in the facility. So you have a child die. The other one was the fact that, for instance, you have a complex system, a very big hospital, for instance, and then a child comes in with a mother and gets lost out in the crowd. The child is convulsing, has a temperature that is very high, critical condition, and no triage nurse picks that person up because the triaging system was not effective. The fast tracking system was not effective. So by the time the person was admitted into the ward for care, the death have already happened. So we had a lot of deaths like that. So approaching it from the clinical perspective rather than from a systems perspective, for us, was one key weakness. But we corrected it quickly as we went along and we learned. And I think it is important that you have a feedback system that you can learn and you can redesign your design as you move along.
A próxima pergunta é uma pergunta pessoal. Querem saber qual a sua formação para a gestão de um projeto tão desafiador? Qual é a sua formação para a gestão de um projeto tão desafiador? Qual foi a sua formação?
Well, it is important that I state that I was one of the key people who worked on the project. I came in as an improvement advisor in 2009, 1 year after the takeoff of the project. I worked till we ended the project in September of 2015, and by that time I was the project lead. Yes, so we had a lot of key people who were leaders. But what I realized is that for the whole team, not just me, it was a multidisciplinary team. We had pediatricians on the team. We have data people on the team. We had public health specialists on the team. We also had, for me, I have a development policy background with a focus on health systems planning. So I was also on the team. We also had people who were nurses on the team. So we have, so it was a multidisciplinary team. So, but beyond the subject matter knowledge that we all had, we also needed improvement knowledge because we're going to be at the forefront of leading this improvement work. And I think this is where the capacity is really important. And even so, at the facility level, it is usually very important that our teams are multidisciplinary. When they are multidisciplinary, there are issues that will come up that people might have subject matter knowledge that they can help to address, whilst they consistently learn, improvement knowledge, how to analyze data the right way, how to take decisions based on the data, and so on and so forth. So I think that is important.
Quais foram os grupos ou equipes mais difíceis para se engajar nos projetos?
This is an interesting one. Yes. My personal experience, because I interface with a lot of the teams in the course of all the work, the teams that were most difficult are usually the bigger teams. So like the teaching hospitals. They see a lot of clients, a lot of patients, and usually they also have the complement of all the specialists. They have the neonatologists, and you know, doctors are sometimes difficult to engage because they know so much, and indeed they do. They do know so much. But, so coming to talk about improving healthcare, and that specialist or somebody who knows so much in his area of expertise, for him to come and say that he has to learn more, sometimes it's a bit difficult for him or her to appreciate. And so initially the engagement is hard, but there are ways of going around this. Usually the engagement should be with data. Well, I recall in one of the teaching hospitals in the north, in Tamale, the place is called Tamale. We went there and we realized that malaria was the #1 cause of under 5 deaths. But malaria treatments are not even a specialized type of treatment. They are just very basic. You just go through a basic protocol. And in the teaching hospital, where they had a complement of all the staff, they had all the incubators, they had all the wards, they had all the space. That was where the burden was even highest. You know, so it was difficult to engage them. But when we put the data before them, and then they asked that, okay, this is the data we have collected together. They, as specialists, also want to go into the records room, work with their records people, and also bring out their data. We allowed that process to continue, and then when they did the same data, they looked through the data. The data corresponded with the data we had gone to engage their team to do. So they then came to the realization that, yes, indeed, there is a problem. So it's about creating a burning platform. Yeah, so anytime you meet a difficult team, you need to have very innovative ways of creating a burning platform. So one is the data, and then number 2 is the story. And I think stories are very powerful. You can bring a client who has ever had an issue, or maybe lost a near-death case of a child, or even a client who has lost a child, to come into the session and speak about how passionate he or she was, and what he or she felt did not happen for him from the care team. Then again, it becomes a bit engaging. So for me, I will only say that every defect is a treasure. And so when this type of engagement went on, it was an opportunity for us to devise means of really engaging so that we can, you know, really have a very good basis for which we do work.
Obrigado. Acho que ainda temos muitas dúvidas, muitas perguntas, mas precisamos finalizar este período e agradecer novamente sua presença, de poder projetar, né, aquilo que, de alguma forma, não só para a segurança do paciente, mas para sistemas de saúde, tem sido uma proposta inovadora pensar como o sistema pode se modelar as necessidades dos nossos pacientes, a necessidade também, hoje nós podemos pensar como as necessidades de um país, né, porque no caso de Gana, eles estabeleceram uma prioridade nacional, né, e colocaram a favor da ciência da melhoria para incorporar, no caso, em Gana. Obrigada novamente.
Claro, ainda temos o almoço para essa interação com os nossos convidados.